Thank you very much, Maria, and thank you all for being connected live with us. It is an honor to share this speech with Dr. Santos, and I also want to thank Candela for its confidence in me. So we're going to start about describing the power or the armamentarium that the Nordlys has to treat vascular disorders. The idea of this device is that it has two systems that permit to treat different depths, and that's very interesting when we're talking about vascular lesions, right? So we have the neodymium that allows us to reach deep vessels, and we also have the intense pulsed light or the selective waveband technology, which is called in the Nordlys, that allows us to reach superficial and mid-depth vessels. So with just one single device, we can treat all type of vascular lesions. So the first question when I am in front of the device is what handpiece shall I choose depending on what I want to treat, right? So these are the different handpieces that the Nordlys has for its IPL, right? The most used ones are the PR 530 and the VL 555. The PR 530, it does not mean that it only emits at 530. You know, it's an IPL, so it has some filters in it, and it emits between 530 and 750. So this handpiece is more superficial, it's more aggressive for the superficial melanin, and as so, it's more efficient if you want to treat superficial pigment. On the other side, we do have the VL handpiece that emits between 555 and 950 nanometers. So it's thought to be used for deeper structures. So it's safer for the superficial melanin. So it's less efficient if you want to treat pigment. Okay, so this is an overview of the handpieces that the Nordlys has in terms of the IPL. Here we see the wavelength spectrum and all the absorption that hemoglobin has. And we see that with the PR and the VL handpieces, we can aim, we can aim to different depths of that structures, and we also have the neodymium that goes very deep. All right, so we can reach a lot of depths in our skin. So the theoretical recommendation on the IPL of the Nordlys is using the VL handpiece for violet structures and also for lentigos because it's safe. And the PR handpiece should be used for pink and red lesions. But it's a recommendation, but it's not obligatory or compulsory to follow this rule. Actually, if you want to treat melanin, we can use the VL for darker pigmented lesions because it's a safer wavelength because it goes deeper, but we can use the PR for light and intermediate pigmented lesions because it's more superficial, so it's going to be more efficient to treat superficial pigment. If we want to treat the hemoglobin, we should use the 555 handpiece if we want to reach deeper vessels, so they are darker and bluer. But if you want to reach more superficial vessels, which will be red or pink, we should switch to the PR handpiece. All right, so we see that with both handpieces we can treat either melanin or hemoglobin, and we can also switch between depths in our skin. All right, so this should be my advice or the way I use these two handpieces. So when I'm treating darker phototypes or when I'm treating a pigmented lesion that has abundant chromophore, or if I want to treat simultaneously lentigos and deep vessels, I use the VL handpiece. And on the other side, if I want to treat lighter phototypes, or if the pigmented lesion has scarce chromophore, or if I want to treat lentigos and superficial vessels simultaneously, then I switch to the PR handpiece. All right, so that would be my general advice on how to use these two handpieces. So what is the NDAG intended for? This third handpiece is used for deeper and larger vascular structures. So normally, whenever we see vessels that are wider than 1 millimeter approximately in diameter, we may switch to the neodymium YAG. It's also very powerful. You know, most of the IPLs work between approximately 10 joules by square centimeter, and the neodymium is a laser that works approximately at 100 joules centimeter square, right? So it is a very potent laser. So it's intended for high flow vessels when I need a lot of power to collapse that vessel. For example, the nasal LA telangiectasias. It is actually this indication is dangerous if you use a high potency laser as the neodymium, but it's the most effective one, okay? And the neodymium is also intended to be used more in the body than on the face, because it's the more aggressive or dangerous laser, right? It may have, I mean, you may see a very good end point, but you may have an unpredictable result with this, right? It's not strange that you can cause some ulcers or crusts in the nasal LA if you use the neodymium YAG at high energy, right? So most of the times, if we're treating vascular lesions in our body, we should use the neodymium YAG. And if we use the YAG for the face, we should be careful with its fluence. So the second question, when I have selected the handpiece of the Nordlys, is answering if I need a single or a double pulse, right? And the rationale behind it is because if I do a double pulse, I transform the oxyhemoglobin with the first pulse into methemoglobin, right? And it changes the curve of absorption of the hemoglobin. Methemoglobin has more absorption for the second shot, right? So if I see a structure that has scarce chromophore, for example, I tend to use a double pulse. So I make sure that with the second pulse, the structure will absorb the second shot, okay? It allows me to use less energy if I use a double pulse, because methemoglobin has more absorption, and then I'm making a safer treatment, all right, because I'm using less power. So as I said, if the scars is chromophore, it is a good idea to take profit of the second pulse. If you leave some space in between the first and the second pulse, the skin cools down, so we're increasing safety and we are reducing the risk that the vessel explodes and causes purpura, right? So the double pulse should be for increased safety and for vessels that have little chromophore. Now I'm just going to show you some clinical cases. Dr. Santos will show you many more, right? I've spoken more theoretically than he will. And let's see here some clinical cases. So we see an erythematotelangiectasic rosacea here. We see some areas that do have diffuse erythema with little chromophore, but we also see large vessels with a lot of chromophore, especially on the nose, right? So I selected the PR handpiece because this patient is light-skinned and these vessels are superficial. So that's why I chose the PR handpiece. For the diffuse erythema, I first made a pass of a short pulse and a high fluence because I'm treating small structures with scarce chromophore, and that's what they need. And for bigger structures with a lot of chromophore, what I will use is a long pulse and low fluency, right? So what I did is a first pass of 2.5 milliseconds, 6 joules for the diffuse erythema, and then I switched to 9 milliseconds and 10.5 joules for the large vessels, right? So this is the before, and this is the after one single session with these settings I told you. I would like to do the second session for the nose vessels, but the patient was happy enough with the result of a single session, so he decided not to go further with this treatment. All right, so here's a very common case. These are perinasal telangiectasias. This patient was first treated with the Nordlys with a double pulse of 1.5 milliseconds and 6 joules, and it did not respond. Okay, so when I saw this patient, I thought these were mid-large vessels and that they had scarce chromophore, so I thought it to be better to use a PR because they are superficial vessels and it's more aggressive. And I used just one single pulse, mid-length, because it's a quite big structure, and mid-high fluence, right? So these were the settings that I used for this case, and this is the before and after. So the first time that this patient was treated with 1.5 milliseconds, this pulse is too much short for this such big structure, right? So here's the trick. This is the last case I'm going to show you. This is one patient that has a capillary malformation and spider nevus, right? Because these two structures have superficial and deep component, I used the two hand pieces of the Nordlys, right? I first made a pass of PR to treat the superficial vessels with the settings that you are seeing here. And secondly, I made a second pass in the same session to treat the deep structures, right? So for the spider, for example, I used the PR for the peripheral vessels, and for the central vessel, I used the VL handpiece. So my overview on the Nordlys in the treatment of vascular laser, lesions is that is a useful device for any vascular lesion because it has different wavelengths, so it permits you to get to superficial and deep vessels. It normally does not cause purpura if you compare it to the classic PDL settings. It does not have consumables. It's more eco-friendly than the PDL, and it's also great for pigmentary disorders. You can actually treat lentigo simultaneously, and you cannot do it with the PDL, right? So these should be the advantages of the Nordlys in front of the PDL. It also has another hand piece to stimulate collagen, which is the non-ablative fractional laser. So with just one single device, you can treat pigment, you can treat hemoglobin, and you can also treat collagen. So that would be my overview of the Nordlys in the management of vascular lesions, right? If you have any question at the end of this session, we'll have a Q&A section. And now I'm just stepping aside, and Dr. Pedro Santos will follow the speech. So thank you very much.
Hello, everyone. First of all, thank you, Didac, for your magistral presentation. You made my life pretty easy right now. And I would like to thank you all to be with us this evening, to discuss a little bit more of vascular treatments using Nordlys and its patented technologies such as the selective waveband technology of its IPL that is unique on the market. So let's cover a little bit of everything on vascular indications. But first of all, I will only like to summarize a little bit what Didac told us. So when we face a vascular problem that we want to treat, and after having obviously the diagnosis of the lesion, we first have to select the handpiece. And the PR should usually better on pink and red lesions, and it's easy to remember because PR we have just the two letters for guide us, and guiding us also on the VL we have the violaceous lesions, but also on lesions that have higher chromophore density, for instance. We also have an NPI available that will suit us to treat dark or deeper lesions and is safer to use on dark or tanner phototypes. Concerning the pulse duration, we will divide, and I will divide this presentation into major groups: the microvascular issues and the macrovascular ones. In the microvascular issues, we should follow a strategy of short pulse, either single or double, as the doc already told us. And our short pulse will always be below 8 milliseconds. If we have a macrovascular structure to treat, we will use mainly a single pulse with 8 milliseconds or more. Probably you are asking how to divide a microvascular to a macrovascular, and basically we divide them with our eyes. Is saying that if we can clearly see the structure, we are on behalf of a macrovascular one. If we can't individualize the vessels on the structure, in this case we are facing a microvascular lesion. About affluence, I would like to remember a tip and a trick to use safely the SWT technology, that is to decrease 1 joule per centimeter square on bony areas and reduce furthermore 25% on thin skin or on extrafacial areas. I would also like to remember you that we should increase the fluence with low chromophore density to achieve the needed results. Starting with microvascular indications. First of all, and I think the most common one for everyone on the audience, is rosacea. So following a flow charts to set up your treatment, first of all, you should assess the chromophore density. And obviously, we know that our rosacea usually has a chromophore that runs from pink to red. So our main handpiece to go is the PR 530. If we are facing diffuse redness, just a diffuse erythema, we should go with a very short pulse, around 1.5 milliseconds. And if we are facing a microreticular or telangiectatic pattern, we should go with a double pulse of 2.5 milliseconds with a delay between them of 10 milliseconds. And this will increase the efficacy, as Didac already explained us. We should always overlap with this technique, around 50%. Why? Because when we deliver the energy on the skin, the energy will suffer diffraction, and below the skin surface we will have like a cone facing with the bottom to the skin of useful energy. If we overlap, we get a uniform penetration along all of the lesion to treat. After this, we should be care about the pressure that we perform the treatment, because if we exert too much pressure on the skin, we will take out the chromophore that we need to treat this condition. Usually we need 2 to 4 sessions 4 weeks apart, and as rosacea is a chronic skin condition, usually it's needed maintenance, but usually as the course is different from every other patient, what we should tell the patient is that we don't schedule the maintenance, but when the patient start to feel symptoms or see redness, you will need to come back to perform 1 to 2 sessions, and usually this happens 1 to 2 times per year. Here we have some results. On the first side, we have just diffuse erythema, and with 3 sessions of the very short pulse of 1.5 milliseconds, ranging fluences between 5.5 to 6 joules per centimeter square, we have this nice clearance. I think that probably on the audience we'll have some PDL and KTP experienced colleagues, and you know that sometimes the diffuse erythema and the flushing is quite hard to treat and quite hard to have a significant result. So if we use the IPL that allow us broader coverage, we sometimes get better results when compared with these other two technologies. On the other hand, at the right side, this is a patient that has a mixed condition between photoaging and some rosacea. And with a single treatment with the double pulse strategy for treating the photoaging and the vascular part, you can see a pretty nice clearance on the vascular part. Talking about another microvascular condition, talking about capillary malformation or the benign vascular tumors, such as the hemangiomas and port wine stains, the flow chart that we should follow, the structure is pretty much similar to the rosacea. But first of all, we will assess the chromophore density, and if we have a pink or red lesion, we will go with the PR. If we have a violations one, we will go with the VL. On this case, we should always double pass. And this is being stated by several papers. And the first pass is to induce the generation of methemoglobin, and for reducing the thermal impedance of the skin and of the lesion. And we should do the first pass with a not so short pulse of a minimum of 5.5 milliseconds with medium fluence, ranging between 7 to 9 joules, and a second pass that the idea is to be photopurpuric in inducing a pretty amount of purpura with a pulse duration ranging between 0.5 to 3 milliseconds. At this point, even if we wish to go to a non-purpuric setting, we know that for treating capillary malformations and vascular tumors, the efficacy is still pretty much significant with the purpuric strategy rather than the other one. On this case, as we are inducing bulk up eating of the lesion, we should wait 6 weeks to perform next sessions of the treatment of these cases. Here I'll share with you a case of a port wine stain of a 3-year-old girl, and with just 3 sessions, we actually have a result that is pretty similar to a PDL device. So we can actually achieve a nice amount of purpura even using an IPL. And this is because we have the only IPL on the market that allows us to perform a single pulse with a duration below 3 milliseconds. And we can also eventually reach the 0.5 millisecond pulse with Nordlys. And this is pretty a unique setting and feature of this system. Passing to the macrovascular indications. Here we will discuss the telangiectasias and other vascular lesions. Basically, the flow chart is pretty much the same. We will assess the predominant chromophore tissues, the MPs, pink and red, the PR, purple, the VL, and if we are facing a darker or deeper lesion, the NDI. Here we will use the selective photothermolysis theory, as we are increasing the pulse duration with larger vascular volumes or with increased dimension of the lesion, and the reverse is also the same. When we treat single and isolated lesions, we should always isolate the surrounding skin to not damage structures that we don't want to. Basically, this is a short version of the SPTL theory applied to vascular lesions. And what we are using on concrete vascular and macrovascular lesions is what we call mainly a square pulse. What is a square pulse? Is roughly a structure of pulse that have the same fluence for the same pulse duration. And with thin vessels, we will use 8 to 10 square pulse. With a medium vessel, 11 to 13, 14, and with thicker vessels, 15 or more square pulse structure. Here we have an example treating macrovascular structures, on this case, telangiectasias on the face with pretty high volume. On this case, we are using not the PR, but the PRS from small. If you check on the video, it's an hexagonal small handpiece for precision treatments. And we are using a 15 millisecond pulse duration to photocoagulate these lesions. Here is an example using the VL, as we are facing darker and deeper lesions. Here the VL is the way to go, with a square pulse of 15 joules per centimeter square. Here another example, more thin telangiectasias and more superficial. So the way to go is to use the PR with the square pulse too. We can also treat cherry angiomas, and this is a pretty nice indication that goes well almost with any applicator, even the PR, the VL, and the NDAC too. And usually with a single session, we have a nice clearance of the lesions. Here, Venus Lake, a pretty dark lesion that can be treated with the VL, but for me, as this is a high volume vascular lesion, for me the way to go is the neodymium YAG. And here you see a single treatment where we have a complete clearance of the lesion and without any scar left behind. We can also treat leg veins, but on the leg veins, with Nordlys, we should only go with the NDAC because the IPL is not enough to get to the depth of this vessel. So legs is a synonym of using NDAC. Let's cover some other indirect vascular indications, such as active acne. For me, this is a mandatory indication. If you manage acne on your practice, it's a pretty nice help to other treatments, even with oral retinol derivatives such as isotretinoin. and we know that we don't have an important risk using and combining these two strategies. And IPL is useful because we know that we have a thermal sebaceous downregulation. We have a bacteriostatic effect on the C. acnes because of the activation of the protoporphyrins and reactive oxygen species generation. And we also have significant evidence for this low wavelength of its anti-inflammatory effect. So if we are facing an active acne, we should use the PR530 with a double pulse strategy, ranging effluents between 6.6 to 8 joules per centimeter square. And please don't forget the acne-related erythema, the erythema that is left after the main inflammatory part of the lesions is gone. But please remember that this erythema is a surrogate of inflammatory activity too. And here we should go with a very short pulse of 1.5 milliseconds. Our endpoint is a superpuric one where we can appreciate the darkening of the lesion and immediate fade out of that darkening. And usually this is achievable with effluents ranging between 5 to 6 joules. Here we have an example of a patient after 2 sessions of the PR to 530 and combined with oral isotretinoin 10 milligrams per day. And we all have to agree that this is a very nice control of the pathology. And please note that even the residual erythema is pretty well controlled. For me, the very nice indication is the periocular photorejuvenation on the vascular part of the under eye circle. If you notice here, we have a reduction of the vascular component, and even the shadow that we have here is pre-reduced with only two sessions of PR. What we do is to perform vertical applications of the PR530 with a double pulse strategy. And usually with 3 to 5 sessions, we have a pretty nice clearance on the vascular part of the dark circles. Another indication that is rising every day more is the inflammatory part on the blepharitis. And this is one of the indications that is supporting every day more the anti-inflammatory effect of the IPL and SWT on inflammation, modulating some ILs, namely the 17 and the 34, on the inflammation on these cases. Let's go a little bit beyond vascular and talking about numbers. 9 out of 10. What could this represent? If we go through some pretty common indications and concerns of our patients, if I asked you how many patients do you have without any of this one, such as photoaging and all of its consequences, rosacea, other micro or macrovascular issues, textural impairment of the skin, wrinkle, active acne or acne scars, surgical scars, traumatic scars, strias, even red or white, leg veins, warts, onychomycosis, HPV, skin infections, or unwanted hair. Probably you won't find any of these or any patient without any of these conditions. So if I tell you that 90% of your patients could use a Nordlys treatment, this is actually true. So please have all of these indications in mind and acknowledge that adding technology to your practice is a differential way to present you to your patients and to outstanding results and bring the results to another level beyond the traditional techniques and non-technological ones. For finishing, we all have to agree that Nordlys has some unique features, and on SWT, I would like to outstand and outpoint the narrow band that allow us to have more efficacy and more safety on our treatments. We can be more effective with fewer sessions, with less fluids than comparative technologies. We have a scalable technology that allow us to grow with our machine and adding more applicators. We have, rather than the SWT ones, we have two non-fractional ablative lasers, the erbium glass one of 1550 and the thulium one of 1940. This last one is the last addition to the system that allows us to treat more superficially and to deal pretty efficiently with diffuse pigmentation and eventually with clinical keratosis. And when we talk and when we face vascular indications, if we combine on our system a PR, a VL, and an ND piece, we actually have a complete vascular station treating almost every condition that is treatable by technology. We have a user-friendly platform with a user-guided interface. We don't have any consumable, so it's a profitable with a low running cost, and we can, with all of these, provide high satisfaction rates for you and for your patients. Sorry. So I would like to end with a provocation and dare you to turn your practice from a 9 to 10 to a 10 out of 10 with Nordlys with this outstanding technology. Thank you very much. I would be glad to answer your questions joined with Didac, and thank you for watching us.
Thank you very much, Dr. Barco and Dr. Santos. We received a couple of questions. The first one from Jeremy Martins. So he said that, first of all, he thank you for your advice and your experience, and he has two questions. First one, in rosacea, what is your endpoint, a purpuric or a suprapuric reaction, or none of them, in order to avoid PIH?
Who shall answer to this question?
He sent it at 9:30, but I think you can both give your perspective and experience if you agree.
All right, so if you permit me to start first, I tend to never use purpuric settings with an IPL, except for capillary malformations. I tend to do maximum 2-3 shots per area, delayed a few seconds and applying ice. So the idea would be not to have purpura to treat a rosacea, because many times it's not just pure redness or pure telangiectasias. Many times they have both structures. So I do not tend to seek for purpura when treating rosacea. What's your point of view, Pedro?
For me, on rosacea and with IPL, I don't think that we don't need either a suprapuric, not even a purpuric setting. What we are seeking, and mainly with diffuse erythema, we don't have a concrete endpoint. Our endpoint will be a slight erythema, and that's it. Because when we get eventually to a suprapuric reaction with an IPL, and I should underline with an IPL, because if I would go with the PDL, I would seek to a suprapuric setting. But with an IPL, as we have a band and not a single wavelength, if we seek a suprapuric setting, probably you will have a significant edema on the post-treatment that won't be significant or beneficial to your patients. So I would rather prefer to perform an extra session with a milder setting rather than to seek for a suprapuric or not even a purpuric setting.
Oh, just a consideration to that, let's not forget that Nordlys is beyond IPL as for the SWT, so the selective waveband technology, right? So it's another level above IPL. Second question is, it says, if he understands, you choose double pulse if you have a low chromophore density and one short pulse if you have a big chromophore density. That's right?
If I may answer first, I don't think it's much correct. I mean, let's say in general terms that the length of the pulse or the volume of the structure that you're treating is what determines the length of the pulse that you're using. And the quantity of chromophore that your target has is what determines the fluence that we're using, right? But they are interrelated, okay? So if you have a big structure with scarce chromophore, I'm going to use a big pulse or a long pulse with high energy, okay? And vice versa. So if you have little chromophore, you will need high fluence. And if you have a small structure, you will need a short pulse. So in general terms, that's what I would say. I don't know what to think about it, Pedro.
You just explained it for me just perfect. So I don't have any to add for you what you told about that. 100% agree.
Thank you.
Thank you. Next question. Is there any application of fracs for the use of capillary?
As far as I'm concerned, not directly, but indirectly. So it's said to be that applying a non-ablative fractional laser, it enhances the collagen and the matrix where the vessels are embedded into, and it may secondarily improve, for example, rosacea. But I mean, it's not a main indication of this, right? So as far as I'm concerned, that's the only thing I can tell you about this.
I think that the question is going towards for hair regrowth more than capillary.
I think
capillary.
We
I'm
translate
sorry.
capillary from capillary, so my fault.
Oh, I'm sorry. We were speaking about vascular lesions, so I thought about capillaries. Sorry. Go ahead then, Pedro.
So actually, for Nordlys and for Frax applicators, there is no approved indication for that. Said that, we actually have some data and some evidence that both of these wavelengths, namely the 1550 and the 9040, have some ability to activate the WNT pathway and to induce some regrowth of the quiescent follicles. But as I was telling you, there is some data concerning it, but we don't have approved indication. But for me, it's a pretty nice off-label indication to use, let me say.
Thanks for saving me, Pedro.
Then another question we have is, would you treat facial telangiectasis and rosacea on the same session? And if so, would you use, now I will then NDIAC SWT or just SWT?
As for myself, I would treat both things in the same session, and depending on the depth and the width of the vessels, I would also use the NDAC altogether with the SWT, right? So it depends on the vessels. If they are superficial, I would just use the SWT. If they are deep and violet, and most of the times they are in this buccinador area. For this area here, the neodymium is just spectacular, right? So yes, you can combine both wavelengths, always using a lot of ice with the NDAC, or at least the Zimmer or something like that, because the NDAC is a dangerous laser.
And let me add, I'm totally agree with you, with just one exception. That is, please don't use this like a cake recipe. Saying that is saying that if you have a high density of vessels with a background of a high intensity erythema, if you combine the both, you will have a pretty significant heat build-up. So if you have a high density of both components, I would rather treat one at a time. If you don't have a significant density of every part on these cases, and with a nice cooling between every pass, yes, you can perform it.
Thank you. Now, I'm trying to translate this question from Spanish. In rosacea, with which topical treatment you can receive the best results combined with SWT? How can you, is that right? Did I translate well? And how can you obtain the optimal results with the combination treatment?
Yeah, you can use topical ivermectin and you will have better results than just with ivermectin or just SWT, right? SWT and ivermectin, I mean, they work differently. They are both anti-inflammatory, but the SWT is more anti-inflammatory and the ivermectin is more, it targets more the Demodex. So they have different mechanisms and they both work together. So yes, I can combine both.
I would also combine it with oxymetazoline topical, meaning combining the ivermectin, the oxymetazoline, and the IPL. For me, is a holy triad.
Next question. After purpura, if we get the brown color, is that a real PIH or is just degraded hemoglobin to hem group? Dr. Cristina Ono.
Well, that's a tricky question, and I will answer in a very practical way. Does it really matter? I honestly don't think so, because the treatment is exactly the same. I mean, the idea, if it is whether a hyperpigmentation or whether it's hemosiderin, the idea is treating this with Klickman formula or modifications of it, and also oral tranexamic acid. And may you want to apply a laser, I would go with a picosecond NDAC. I don't know what's your point in this, Pedro.
Actually, if we get a true PIH on a purpuric setting, usually is for a defective aftercare on the treatment. I'm not saying that we are misprescribing the aftercare, but usually not sufficient compliance of the patients also with post treatment. But on purpura, what I actually see more is an hemosiderin deposit rather than true PIH. And actually, treating with liposome lactoferrin and eventually the performing a PR 530 with pretty short pulse of 1.5 with medium fluence usually help us getting rid of the hemosiderin deposits with a pretty nice result. If it's PIH, it has to be treated with the usual care of the pimentins, the oral tranexamic acid, and very intensive photoprotection.
Thank you. Then we have Dr. Pilar Yesui saying, thank you very much for the presentation. Another excellent presentations from Latin America, Dr. Geminiani, and he has a question. When you treat rosacea, you use the first pass of 6 Java 1.5 millisecond for small vessels, and then a double pulse 2.5, 10, 2.5 millisecond, and 8, 9 joules, and then a square pulse for big vessels like 10, 10, 13, 13.
Yes, that's what I would use. And I'll tell you the rationale because of that from my point of view. When you do the first pass of the SWT, you create erythema, right? And this erythema is superficial. So if you first create erythema, you then have to switch to safer settings of the laser. And safer means a longer pulse and a lower fluence in relation to this longer pulse. If you do the opposite thing, if you first treat the big vessels, you then create erythema and then you use aggressive settings such as you mentioned 1.5 millisecond, 2.5 milliseconds, you are having high risk of a burn, right? So yes, you're right in your question, and the rationale behind it is, at least from my humble point of view, is what I told you. I don't know what's your point in this question, Pedro.
Dr. Caesar's also asking, is this taking place in the same session then?
Yeah, it's in the same session using ice pack or Zimmer or cold or whatever you have.
From my point of view, is actually that is, but on the short version is when we combine passes, technologies, whatsoever, we have to have in mind that the next step, we cannot create a chromophore for the next step. If we are doing that, we are increasing the risk for side effects. Okay, so basically we have to have the reverse order. So if we know that this pass will lead to an endpoint that is a chromophore, a target for the next step, we should reverse the order. Okay, and for me, on the actual same site, I actually don't perform more than 2 passes. So on your sequence, Franco, that you stated on your question, I would perform, for instance, if I have an diffuse erythema, the 1.5 pass, and after that, if I have a microreticular zones, the double pulsed 1, and on the bigger vessels, the square pulses, and not the 3 on the same site. Okay, this will lead to a significant thermal buildup, and that will lead to possible side effects.
Good, thank you. The next question. If purpura did occur heavily with sensitive skin, what is the corrective course of action to treat it, and does it affect the duration needed between sessions and or the settings used in the second sessions?
Since I don't have a PDL and I do not tend to have purpura on the sessions, I think that Pedro would be the best one to answer this question.
First of all, if we have a purpura that is occurring heavily, probably our settings are not the proper ones to treat the condition. We only seek for heavy purpura on vascular malformations or vascular anomalies. Okay. Beyond that, we should get away from purpura for its risks. Okay. And on a sensitive skin, I'm afraid that I cannot define concretely what is sensitive skin, because we are treating vascular anomalies on newborns, and they have a sensitive skin, and we seek for purpura. So basically the post is to apply a very low potency corticosteroids such as hydrocortisone, and moisturize that skin, and that's it. What is a pretty sensitive skin? I actually don't know. And on pretty sensitive skin, I would rather not seek for purpura rather than to seek that, because the only indication for me for a significant purpura is the vascular malformations or anomalies, or eventually the matting on treating matting on legs after vascular treatment.
Thank you. How do you approach vascular component of melasma?
First of all, praying. No, just kidding. I mean, normally I do give oral tranexamic acid. I normally do not tend to use IPL or SWT systems with the in melasma, because I mean melanin is just up there and it's going to absorb part of the energy. So if I would have to choose a device for that, I would go to a PDL that has not that absorption for melanin in subpurpuric settings, because I don't want to cause an inflammation. Or I may go with the neodymium YAG in a very short pulse mode, for example, 0.3 milliseconds. That's the maximum thing I would do in terms of vascular devices in a melasma. What's your point, Pedro?
Totally agree. There is a nice paper that has a couple of years regarding the vascular component of melasma, and states actually the importance of the oral, and I should underline the oral tranexamic acid rather than the topical one, and the use of vascular lasers, and on this point strictly the PDL and the sub-millisecond neodymium YAG. The PDL usually we use as a reference the 10 millimeter spot size, with pulse duration ranging 3 to 6 milliseconds, so a non-purpuric pulse duration. And we choose this pulse duration because we know that the anti-inflammatory properties are maximized on this pulse duration, and the fluids usually ranging 4 to 6 joules. And using neodymium YAG, we use the sub-millisecond way with pulse duration ranging between 0.3 to 1.6 milliseconds, so 300 to 600 microseconds, with 8 millimeter spot size, 8 joules of fluids with an high frequency, so usually 7 to 10 hertz, and doing a sweeping motion to cover the area with 4 passes. And after this, using some topical anti-inflammatory as a low potency corticosteroid too. But yes, for me is not an option to treat melasma.
There's another question related to the melasma vascular. What is needed for vascular melasma on latent skin, phototype 4? Which are the parameters that you would use for nose over pigment the skin? That was.
Well, I think that
Is that clear in English? Otherwise, I read it in Spanish for you again.
I think that Pedro has just answered this question.
Right?
As
That
far
was
as
sent
I'm
privately, so I just received it now. But perfect. Then we have several people saying thank you very much. Everything's been very clear. Greetings to me too. I say hi back. And then another question I have here from the chat. Any role in rhinophyma in flushing?
I don't think that the rhinophyma improves with the SWT or a neodymium yak unless it has a clear large vessel in it. And about the flushing, I've experienced good responses with very short pulses and high energy. For example, 1.5 millisecond, 8 joules, and also combined in the same session with a neodymium yak sub-millisecond, 0.3 millisecond, right? So combining both wavelengths, I have, experienced very good results in this term.
I'm totally agree with you. I mean, with the flushing part. The rhinophyma is a surgical issue rather than an inflammatory one. So you have to go with an ablative wavelength. So a nerve yak, a CO2, to deal with the amount of tissue that is redundant. And after that, after reducing the tissue, yes, you can use and PR, for instance, to reduce inflammation, to maintain the condition. But the first line is not to use the SWT or the Nordlys system, but the core one, for instance.
Thank you very much. We don't have further questions. Any comments to conclude the webinar?
I just would like to thank you all for being connected at this time and hope that all our messages, have reached you clearly, and you do have my or our emails just to contact us if you have any further inquiries.
I make your words mine. So basically, is that thanking you, your presence here, your company, thanking again Candela to allow us to improve every other day, and thank also the Candela team that is here, Samantha and Maria, and it's always a pleasure to co-share the stage with you, Didac.
Thank you very much. I think exactly the same. I always learn with you.
Thank you both. It has been great to work with you again. Thank you also our audience for joining us today. Thank you very much. This is the end of the webinar.
Thank you. I will end the recording now.